Okay, we're going to move to the next session, which is going to be on trauma. I'm Max Boachi from University of Louisville, and I'll be moderating with Jesse Bible from Penn State. Okay, we were supposed to go into our debate session, but Corina, unfortunately, is feeling sick from her family had some COVID, and she wasn't feeling well, so she's not going to be here today. So instead, we're going to have Jim debate himself. No, just kidding. Jim has graciously accepted to kind of talk about the pros and cons and get some help from the panel as needed. So there we go, our ex-president.
Thank you very much, Max. First of all, you know the guys hate you, the moderators, when they give you a talk to debate something you have about 35 papers that say the opposite. So I'll get even with all you guys. All right, so the Vegas odds on me actually went down once I had to debate myself, so that's not good. My disclosures, I work with Depew and Ethicon. So Corina, I don't know if you guys all know Corina, very bright, intelligent person. Probably only one of her flaws, she was trained by Nick Theodore, so that's a strike against her. She was supposed to come here, but Thanksgiving happened, she had a little sniffles. Now, we could say that she got COVID, but I don't know. I just don't think she was ready and prepared to debate me. And I will tell you, I gave these guys the option to debate me, and they all wimped out. So it's 100% true. I'll show you the emails. But I will tell you, I saw her slides, and I don't blame them for not picking it. We did actually use the QR code on this, and it turns out it was from 2019. So I'm not really sure she's that sick if anyone wants to go out with her tonight. This was probably the best slide she had. And so a little self-deprecation, I'll give it to her. That's pretty good. And you can't usually have a debate with me without using the old McLovin slide. And with that, we're going to switch gears. So I'm going to go through, and I think I heard it a couple times today, we have to stop boxing patients into areas. The days of saying we have a geriatric spinal cord injury, a geriatric odontoid fracture, they need that. I don't know why my slides are advancing, guys. If we could stop them. But we have to stop and say, box, type 2 odontoid fracture, everyone needs to be treated. We have to start looking at individuals. And I'm going to show you a summary of my whole slide if someone wants to go out and get a drink, is that benefit of surgery is going to go away as our patients get older or get sicker. So the RVUs stay the same, but the benefit to the patients go away. So be a little careful on how you operate and what you operate on. So just since this is an instructional course, 3 different types of odontoid fractures, I still am not totally sure I've ever seen a type 1 odontoid fracture. Who's seen a type 1 odontoid fracture? Okay, you're delusional, so that's all right. You're the guy that wants to do anteriors on the stiff patients. We'll debate that a little. In the discussion thing, we'll talk about that a little too.
Just continue, Jim.
So anyways, I think type 1s, if you see a type 1 odontoid fracture, be careful. It might be an AO dislocation because you could have pulled off the apical lip. Type 2 is very common. Why is it a big problem? Is the slide on the left is scary. Unless you're my age when you're going, oh, cool, I'm going to live to be 80. But the population that's living 80 is amazing. I mean, I go to a clinic now, and all I see is 80-year-old people, and that's usually my patients' children. So be careful. Again, type 1 odontitis, there's a little bit things. Type 2 odontoid fractures knock off the peg. They don't get revascularized, and that's why they don't heal up that well. There seems to be a misconception that there's such thing that exists called a shallow type 3 odontoid fracture, which is equivalent to a type 2. Maybe it only happens at Jefferson, but by definition, I'm going to make it really easy. If you look at your coronal CT and the fracture goes into the facet line, by definition, it's a type 3. That should heal, and you don't need to operate on it. All right. Second part of the debate, and actually Corina and I both agreed on this one. The days of the halo are probably over. I'm writing a paper now. We're looking at the halos use in Nacton, and it's amazing that I don't think anyone knows how to put halos on or do traction anymore. It's always funny when someone goes in a halo, about 6 hours later, someone finds the halo screwdriver. I mean, that might not be at Metro. You guys still have these on? Cutting edge 1970?
Put one on last week. Yeah.
There you go. All right, so Halo Fest, why? And the elderlies do not tolerate halos. They do extremely poor. There's numerous articles for this. So I would tell you, be very careful. And what I'm saying is a guideline. So use with that what you want. Now let's go to odontoid fracture. This is a Cochrane review. Whenever you have to do a debate on something, or I always go to Cochrane and I say, okay, what's out there? Since 2008, the data hasn't changed significantly, and they have not updated this. So this is one of Karina's papers where she was going to attack me and assault me, and that's all right, because most of my papers are not very good, so having to argue against them is pretty easy. I can find a lot of flaws. So we did this as part of the spine study group back in 2010. We looked at it, and we wanted to say, our odontoids, we were getting flooded with all these odontoid fractures. And at Jefferson, every community hospital in the world would send us all their odontoid fractures. That doesn't happen anymore. But it was hilarious. We had all these odontoid fractures, didn't know what to do with them. And some of them did fantastic. You know, we used to reduce them, and we had a high mortality rate. It's a bad disease, you know, when you look at the mortality rates on it. So we went to literature, and I'll say it really easy. The literature was really not very good at this time. If you go through these are the low-quality papers that I pulled out, and we're going to touch base on a lot of them. The biggest paper was from Harvey Smith, was the Jefferson paper. And again, not very good papers. They really don't say that much. The biggest problem with looking in the 2010 issue with odontoid fractures or trauma in general was what? Everything was based on fusion rates. No one cared if your patient lived or died or had a limp. It was all about, did the bone fuse? And so we had to step back and relook at relook at our outcome measures. So again, I want you to step back and think about this. This patient comes in, pretty easy, 69-year-old guy, getting closer to my age, probably healthier than I am, neurologically intact, significantly displaced odontoid fracture. To me, that's a no-brainer. That guy's getting an operation. The problem is I'm seeing more and more of these. 86 years old, a little minor dementia. And I'm always like laughing. I'm like, you're either pregnant or you're not. You're either demented or you're not. And so these people, they don't know where they are. And so with them, I don't know what to do. And then they're usually on Eliquis, and their cardiologist wants to do something. And so it's a big debate on what to do. It is true, we are doing better surgically, and I think that has to do with timing, and I think our anesthesia colleagues are helping us out. We are able to get away with operating a lot of older people safer. Now, the converse of that might not necessarily be true, that since you're old, we can safely operate on you, because they do have a higher rate. So this is actually Alex Vaccaro's paper done with the AO. Now, Alex Vaccaro will tell you that this is a prospective study, and it doesn't matter that it's a cohort study because his decision tree doesn't have branches. But what happens is as you look at cohorts, they're cohorts and they're put in boxes for a reason, right? You walk in the room and the guy looks like he's not going to survive. You're like, okay, I'm going to put him on my non-operative slot. And if the guy looks unbelievable, or lady looks unbelievable, you're like, okay, that person's going to probably tolerate surgery, and that's called a selection bias. And that's the biggest problem with the odontoid patients. Multiple different people are trying to do prospective randomized studies, but it's hilarious because patients never want to. If you tell an 80-year-old person they can wear a collar or get a surgery, you know what they say? I'm going to wear the collar, leave me alone. And so it's really hard to randomize people. So with that said, is the other thing you don't look at is 66 of the patients were excluded in this group. The surgeon declared treatment, and the way they got their outcomes is they went back and said, okay, demented patient, I want you to remember the day before you had your trauma, can you fill out this SF36? And I know Alex's patients were he filled them out himself in crayon, and they were all like zeros. And so they look so good after his surgery. But the residents, exactly. They're not biased. They don't have a team. Anyways, this paper is probably one of the best papers we have out there, to be fair. It is outcomes. They looked at NDI. It was perspective. They did power analysis, everything you could want in a study. The second thing I want to say is with new innovation or technology, remember this curve, because everything is great when it first comes out. You can think of every device, the Coflex device. Everyone's getting Coflex. And then you go into this period of educating yourself about it, and then you're kind of like, well, maybe it's not great. And I'm going to propose that we are down the road on this. When odontoid fractures came out, we said, let's operate on everyone. And now we've learned that there are subpopulations that we don't have to operate on. And that's most of these 80-year-old patients. So again, this is another paper of mine with this is Yen's paper, and he correctly describes it as a retrospective review. And the big thing that if you read every one of these papers, what do they say? Mortality rates high. The non-operative patients' mortality rate's so much higher. And it always cracks me up. I'm like, that's because they were dead before you freaking operated. I mean, you picked out a box. I mean, we should be more talking about the 5% of people that got surgery and died, because it's understandable that the patients that were 21, the 21%, were probably going to die, and that's why they said, I'm not going to operate on you. The ages were different in the mortality rates, but the big thing, again, and we'll get into this a little bit, I'll talk about it in 1 second. The big thing is, if you look at the mortality rate in all these studies, guess what happens? Once you get out of that 3-month window of, okay, that patient's really sick from getting ran over by a car and has an odontoid fracture, the mortality stays the same in both the groups. And that's followed out 5 years. Those lines are the exact same length, and you can see there's no difference after 3 months. All right, this is Harvey Smith's paper. Again, mortality rates about similar, understanding there's a big selection bias in who has it. But what I want to say, and this cracks me up with all spine papers, we somehow equate adverse events as the same. So if you get your esophagus cut, that's the same as you having a superficial wound infection, based on the way we judge complications. So in this study, we looked at the surgical patients over 80. 25% of them got a feeding tube. That's, a tracheostomy. 18% got a feeding tube. And somehow we're going to go, well, that's pretty close to getting abrasion from wearing your collar too long. So I'm not sure we're really looking at the same things here. Next paper, real quickly. This is a paper that Harvey wrote. Again, I'm on it. And this, to me, kind of changed the way I thought about our odontoid fractures. This is the groups we declared that were failures. So let's look at the failures that didn't heal and got non-operative management. So 14% died in the first 90 days. Well, that's got to be because they were put in a collar, because we know that just murders all of our other trauma patients. Then let's keep on going. The funny thing is, if you follow through the algorithm, 70% of the patients treated in college went on to a stable union. That's pretty damn good. 70% of nothing of mine works. 70% of my lumbar discs don't do well. So keep on going forward, and you say, let's look at this a little further. Guess what? Only 78% of the patients had hard collars. The rest of them, almost 22% had a halo or didn't get a collar at all. So what does that tell you? If you look at it and we treated that whole group in collars, we probably would raise our fusion rate up to 84, 85%. And that's not bad. A couple real quick things. I know I'm running out of time. This is Alan Crockard's paper. Alan Crockard, a lot of people would argue that there's a such thing as called late myelopathy. If you go through Alan Crockard's workup and look at his patients, all of them present with neck pain. So there should be comfort in our minds saying, hey, we can let these patients go out with a fracture, because if they're really unstable, they're going to come back with neck pain. And I'm not saying you don't have to ignore them, but we should follow them. Again, a lot of papers have done this, and I'm just going to go through all these. These are, I forget who, Robert Hart's paper is very well known, 5 patients over 80 years old. The Hannigan paper, again. Here's another Ryan paper. No late myelopathies in all these groups. Matter of fact, if you go to the Ryan paper, they argue you should not vigorously go after stabilization of these patients. Robert Molinari wrote another paper that's quoted all the time, which again, looked at these patients that didn't fuse, and what happened? They had the same NDIs as their cohorts thing. So the other thing that we have to also acknowledge, somehow if you get surgery, you're in the surgical group, you don't get killed, which is good, you keep on going forward, you show up with the pseudoarthrosis, somehow that's fine. So if you look at this study of Bohemianus, 48% of the patients had fusions. But I don't see another paper that says, oh my God, my elderly patient that I failed getting a fusion on has a pseudoarthrosis. I need to tackle them and operate on them because that pseudoarthrosis is going to kill them. Exactly the same we just said to the non-operative patients. So there seems to be some belief that the stability things. This is the Harvard group's paper. Again, really quickly, what it says is the effect of surgery in a hugely selection biased group seems to lose its effect at 74 years of age. And 25% of their patients were treated in a halo. Keep on going through other surgery things. I'll go through these papers pretty quickly. This was one of Karina's papers. I just thought I'd put in something for her. And again, she says that the fusion rates and mortality rates are the same, which is good. Another paper, I'm getting bored. I have so much data here. Last thing I just want to go through, and this is a pretty good paper where they did a meta-analysis. Again, somehow in the world, in other parts of the world, they seem to equate type 2 and type 3 odontoids as the same. So we're going to ignore that, and we're going to look at the geriatric population. And what they did is they broke it out by decade. So if you were 70, and we just had a nice discussion about meta-analysis and how to read them, but you can see what you don't want to be is you don't want your meta-analysis summary to be on your line. That's all you need to know. So if you're 70, there does seem to be a beneficial effect of surgery. Excuse me, less than 70. What if you're 70, 80? Now it becomes non-significant. So you can say there is no statistical difference on the outcomes of these patients. And then if you go to 80, the line keeps on moving. So I think the lesson that we all need to talk about is as we look at patients, as Greg Schroeder did in his meta-analysis in a row, and Greg, I don't know how the hell you picked 60 as elderly. I mean, your chairman is now in the geriatric group. I just want to let you know that. So over 60, you should be selective on who you decide to do. And what we're trying to do is this is just a summary of papers out there that are really trying to understand what is the algorithm we need to do on this population to understand should we operate on them or should we not. So in conclusion, I think that surgery has a definitive role in odontoid fractures. I usually look at them in age as one metric, but you have to look at the physiological health of your patients. I think patients do very well with surgery as an option, but I think not operating on patients and taking patients out of collars with stable non-unions is an excellent option. Thank you.
Jimmy, it's all.
I hope I don't break my neck in Ohio.
Jimmy, and you don't care about safety of your patients, obviously. So, but it's all about the flip, right? It's all about the safety of the flip, because at least in our institution, our experience is, and we've had some really, really bad occurrences with the flip in ankylosing spondylitis patients where they've dissociated, they've lost function, and you ready for this? So, Tim, I've done what you do, put a little plate on, and then our fellows and residents get super aggressive with sandwiching them. And you ready for this? They sandwich them, and in an ankylosing patient with a thoracic kyphosis, they've dissociated the mid-thoracic spine and paralyzed patients. So I've created a lot of havoc in these patients. So it's another thing to just be wary of.
Did you argue for or against me? I think you just argued for.
No, I think it's important to understand the safety. It's really for safety.
And real quick, I think Jim mentioned this, but just in his strange roundabout way. If you're going to be treating geriatric odontoid fractures, your goal is a stable pseudo, okay? You don't need a bony union. So however you want to treat them, you want a stable pseudo. I think that's what's important. And always look at the C1-2 arthrosis. That's very, very predictive. I've gotten a 92-year-old with a type 2 odontoid fracture heal in a collar, but he had minimal C1-2 arthrosis. So stable pseudoarthrosis is the only thing you're looking for.
Thank you. And I had one more question on the same topic there. So I struggle with which is there a subgroup of these patients with the ank-spawn fractures that is actually stable? And I know the classic teaching, unstable, long fusions. We operate on tons and tons of these, but often you'll find one that's almost partial, like partially through the vertebral body, and sometimes they've road tested themselves. So it happened a week ago. They come like walking in, all of a sudden it's like unstable fracture, and they themselves are surprised, and they're like, "I'm bed rest now. I've been walking for days." And so, can you comment a little bit on that, and have we studied that group?
We haven't, but I'm treating upper thoracic stiff spine fractures non-operatively if their sternum is intact and they don't have rib fractures along with it. And I wonder how they ever fractured in that area. But I'll treat those. Oftentimes they're fish mouth, they're opened up. You can't even see the fracture line posteriorly. The ones you have to be very concerned about are those pure axial plane fractures. Oftentimes those are the ones that have a tendency to slip, and it's as you're getting closer to the thoracolumbar junction. Cervical spine, not so much. Typically, those are operative in my hands.
Thank you.
focusing on odontoid fractures for a second. The good news about this being an instructional course is that the mean age of the people in the audience is quite low, and the mean age of you guys is quite high.
Thanks for sharing, John. Yeah.
I just want to put in, our standard deviation is below you, so.
I'll agree with that. I'm officially in the geriatric group, right? Yeah, but I think one of the important points is you come out of training and you've got your nice sharp knife and you've spent the last 10 years of your life learning how to operate, and you can have a thing on your smartphone with an ortho bullet answer that says operate, and you can have a paper in your hand that supports it. The hard thing to do is saying no, right? Very difficult to do. And in the nuanced collection of people who have these elder odontoid fractures, you have the very bright, active, cognitive folks. At the other end of the spectrum, you have people who are badly demented, and the conversation you're having is with their family. And there's a whole bunch of people in between. And you're trying to reason your way through a decision process. How about some thoughts from you guys about that conversation with the patient or with the family member when the patient really isn't participating in the decision making? They're worried about if grandma falls down, her fracture displaces, she stops breathing. Is that a good thing? Is that a bad thing? How do you go through that conversation?
Yeah, I mean, of course, it's a spectacular question from my liege, right? I mean, I think at the end of the day, I mean, if somebody obviously is demented, right, even if they meet operative criteria for at risk for going on to a non-union, I mean, we have that very forward conversation with the family members, and they're often relieved, right? And they're often are coming from an assisted living facility, and we send them out in a soft collar, and we see them in the office, and then they almost get lost to follow up, at least in Maryland. I think what you're getting to the crux of is really frailty index, right? And Jimmy, I don't know if there's any papers you reviewed looking as a surrogate, not age, right? We all see 70, 80-year-old people, but yet there are different levels of frailty, right? And that may be a better sort of barometer of whether or not you should pull the trigger in a non-demented patient, John. So I don't know if there's any data to suggest that, but that's sort of our take, in our institution.
That's a great question, John. And I guess the way I do it, or at least I try to do it, is you got to get the patient out of the hospital situation. I mean, I think if you have any question if you're going to operate on the person or not, put them in a collar, bring the family in, and this is the one group of patients. I usually get the daughter, and I hate to say it, the sons aren't usually as into the patient's health practice as the daughter is, and so I usually call the family, get them in there, and talk to them and say, okay, what is our goal? And a lot of these people don't have big goals. They want to sit in the chair, get them moving around. The bigger question comes in 3 months when they have a little motion on their fibrous non-union. And I just did this yesterday. They were seen by another surgeon that said if he takes his collar off, he'll be paralyzed. And I'm like, I took his collar off, and I'm like, go live your life. You're 87 years old. I mean, you might die, but I told him his chances of dying are better with a knife in my hand.
I completely agree. I hate operating on these when they happen. Unfortunately, I presented last year, 14 of my last 47, we were the 4th institution that the patient had been to on that day. So, and they've been convinced by the other institutions, you need to have an operation, you need to have an operation. I put those patients in a soft collar, I have them back to clinic, and the reason that the patient and the patient's family chooses to have surgery, whether there's this much motion or this much motion at 3 months, is if their neck hurts. That's the only reason they choose to have surgery. They're not scared that they're going to die on the next fall. They're not scared they're going to develop myelopathy. I let the patient and the patient's 70-year-old, offspring decide whether or not they want to have surgery.
Yeah, has anybody seen in the audience with their experience with these octogenarians and above a pseudarthrosis or a non-union of an odontoid that has died suddenly or has developed myelopathy? Like, that's a unicorn in Maryland.
I have a patient that I actually...
Of course you do.
No. Listen, Steve, when you don't sit in the library all day and you operate, you have patients.
Exactly.
I actually have a patient that I came in, had an odontoid fracture, didn't heal. went out, lost a follow-up, came back 5 years later, fell off the toilet, and got a spinal cord injury. So can it happen? Yes.
Yeah,
And
but it's
actually, the
a
family withdrew her
unicorn.
support on
That's
her.
a unicorn, I would say.
No, I totally agree, but it's
I have 1 in 8 years, and it was the same thing, though. I tell
same patient, actually.
I say the same thing. I say, you could die in surgery, you could not die in surgery. Like, but don't do it.
All right, I would say thanks for those words of wisdom, but I think the idea is learn to say no.